I think the whole emphasis on the Brugada syndrome, otherwise you're all going to be extremely late for your lunch. And if you're hungry, there are sweeties in front of you, as my daughter would say. Grab the sweeties. I don't mind the ruffling. So I'm going to be talking about ion channel disease, and just to mention some common features before I zoom in on Brugada syndrome. They're genetic and inheritable conditions. There is variable penetrance, meaning that individuals from the same family carrying the same genetic mutation may have very different presentations and severity of disease. There is also a commonality, generally, of normal cardiac structure, although you may see there's some debate on that later in Brugada syndrome. Ventricular arrhythmia are often the hallmark, causing either blackouts or sudden death if not resuscitated. Long QT syndrome is probably the most common form, but I would say Brugada syndrome is bringing up the rest, and progressive cardiac conduction defect, familial atrial fibrillation, and sinus node disease are closely related to sodium channel disease, which can be associated with Brugada syndrome. CPVT, short QT, early repolarization, these cover most of them. There are one or two other rarer entities that have been described. But as you can see in red, we're going for Brugada syndrome. Brugada syndrome was first described formally as the Brugada syndrome by the Brugada brothers in 1992. There had been some preliminary descriptions from an Italian group in the late 80s that were similar, but I think this probably brought it together in a more seminal way. It's also been associated with sudden unexplained death syndrome, which is a syndrome to describe cases of unexpected and unexplained sudden death in young Southeast Asian men, known as Laitai, Pokuri, Bangungut, different types of terminology depending on the region, and I apologize for my pronunciation if anybody's from those areas. It is generally hereditary, although sporadic disease is recognized. The commonest pattern is sudden death of an adult male in sleep, usually associated with polymorphic VT and degeneration to ventricular fibrillation, although monomorphic VT has been described in some cases. Paroxysmal atrial fibrillation is very common in this young group, and the ECG marker is a characteristic ECG. It can be present persistently, or more commonly as transient, or even more commonly as concealed. In terms of placing Brugada syndrome into context, I just thought I'd give you a little bit of data to suggest what the numbers might be in the UK. So if we have around 50 to 100,000 sudden deaths per annum in the UK, 4% is one of the estimates given for the amount of sudden death related to Brugada syndrome. So that would be 2 to 4,000 per annum. This is across all age groups. In terms of sudden arrhythmic death syndrome, which I think you will be hearing more about today, or SADS, so an autopsy normal heart, morphologically normal. From our data, we would say even up to 40% of cases may relate to Brugada syndrome. The estimate is at least 20% internationally. So that gives you some context. In terms of incidence, internationally it ranges from 5 to 66 per 100,000 per annum, and that really depends where you take your data from. Western Europe probably the lowest, and Southeast Asia the highest. And 1 in 1,000 per annum in Laos in particular amongst young men. It's commoner than dying in a road traffic accident for young men in Laos. So that's placing that into context. The diagnostic ECG that I mentioned, these are different types of ECG pattern. The type 1 ECG pattern, coved ST elevation, maybe even a little bit more coved than this particular example, with deep T wave inversion, is typical for the type 1 pattern. This is the diagnostic pattern. You may also have partial patterns, type 2 and type 3, that have been described. But in the standard right ventricular leads, and if you happen to place your right ventricular leads a bit higher in the second and third intercostal spaces, you will often see these patterns as a range of normal. In fact, up to 2 or 3% of individuals will have these. So I would say this is potentially a normal finding and not a necessarily leap to the diagnosis of Brugada syndrome unless you have any other indications. This is a family member of a young man who had an idiopathic episode of idiopathic ventricular fibrillation and then was found to carry Brugada syndrome after subsequent investigation. So this is his brother. He had a normal ECG at rest, and he received a sodium channel blocker known as ajmaline. Flecainide has been used, maybe less successfully, procainamide and pilsicainide in other countries where ajmaline isn't available, but I would say ajmaline is the best drug. And you can see progressively as the dose is given, there's elevation of the ST segments and J points with a coved ST elevation type 1 pattern developing very early on in this case. So the ajmaline test is often used as a diagnostic challenge and is probably the most sensitive. The diagnostic algorithm that is advocated by the consensus documents of 2002 and then 2005, and I state consensus because it doesn't mean that they're right, they're just consensus criteria, which stated that you had to have a type 1 pattern in more than one right ventricular lead with a sodium channel blocker being allowed to induce that. You had to make sure that you'd excluded structural or other causes. Medications can induce this, and cocaine and alcohol also do it as well if you're not too careful. And then you also need to consider other issues like, do they have documented VT, VF, have they had a family history of premature sudden death, family history of other ECGs, blackouts, inducibility, electrophysiological study, that's quite frowned upon as a diagnostic criterion at this time, and where there may be other nocturnal signs as well. And they stated at this time, the consensus group, that a type 1 only would mean an idiopathic Brugada ECG pattern, not Brugada syndrome. That might beg the question, if you identify somebody with that ECG pattern and they're asymptomatic and they don't have a family history, are they just waiting to have a sudden death, or are they just part of the normal population that don't need to be intervened upon? We don't know. So I think there are some flaws to that consensus document, and there may be some changes to the diagnosis coming forward based on recent literature. Maybe just the type 1 pattern alone will be necessary. Why exclude individuals just because you haven't managed to see their family, or just because they haven't had symptoms yet? Are you going to be missing out on those individuals who are at risk? Only one right ventricular lead might be necessary, rather than just requiring 2 or more. And high intercostal spaces. So using those second and third intercostal spaces appears to increase the sensitivity for the type 1 pattern. And I'll show you a little bit of an illustration of that. In sudden arrhythmic death syndrome, some data from our group indicates that if you use the high right ventricular leads for the diagnosis of Brugada syndrome, you get a much increased sensitivity. And in fact, in our cohort, we do have levels of around 30 to 40% of Brugada syndrome. And in fact, if you use the fourth intercostal space, you get about half of what you get if you use the second intercostal space. And this is some data from Michael, one of my chairs today. And an ECG also kindly from Michael from this series. You have the baseline ECG at the top, and then the ajmaline provocation ECG. Boxed in red are your right ventricular leads of the fourth intercostal space. Now, there is some abnormality with ajmaline, but ajmaline is a pretty potent blocker. It will do something to your ECG no matter what. But there's certainly no diagnostic change. But if you look at the second intercostal space, there is dramatic change that is diagnostic in this individual. So greater sensitivity with the high leads. The question of specificity does arise, but so far our experience has been that specificity is still preserved. The etiology of Brugada syndrome has been related to genetic disease given the hereditary nature of the condition, and there have been a whole range of genes implicated. This is an exhaustive list, and it's growing. There was a publication just last night in Circuit Electrophysiology that introduced yet another gene into the lists. And the most important one to associate is the SCN5A gene, the sodium channel, the cardiac sodium channel, that seems to be associated in around a fifth to a quarter of cases with Brugada syndrome. Calcium channel mutations associated with short QT syndrome and Brugada syndrome have also been detected in maybe a significant proportion of cases, but that was only one series. And a follow-up series has not suggested that they're particularly frequent either. So we're still in a little bit of a frequency desert, as it were, because if you look at what that adds up to, that's maybe a third at most if you add all those possible frequencies up. Most of these are just single case descriptions in the literature. And there's also an association with conduction disease in the SCN1 beta subunit. Now, the mechanism of Brugada syndrome, it may be partly related to these genetic abnormalities, but I'll show you a bit more about the controversy around it. With the genetic abnormalities, you have either a reduction in depolarizing currents, so reduction of that inward sodium current at the beginning of the action potential. I'll just point out over here the upstroke to the action potential where the sodium channel, the inward sodium current, is vitally important to the initiation of the ventricular myocyte action potential. You may also, however, in a couple of forms of Brugada syndrome, have a reduction or an increase, in the transient outward current, the ITO current, which functions just after that phase naught in phase 1 of the initial partial repolarization. This brings us to the potential etiologies. How do these differences in ion channel function feed into the possible pathophysiological mechanisms in Brugada syndrome? And there are two major opposing mechanisms proposed, or theories proposed, although there are subtle variations of both around. That is repolarization and depolarization. In the case of repolarization, if you look at the middle diagram, the transient outward current is particularly prominent in the epicardium of the right ventricle compared to the endocardium. And with diminution of inward currents, it's proposed, or accentuation of the outward current, it's proposed that this results in a heterogeneous loss of action potential dome across the epicardium and resulting in a repolarization gradient across the epicardium to the endocardium that gives the ECG appearance of the type 1 pattern, and that this may be the mechanism for the ECG, but also potentially for re-entry because of the nature of the substrate. It's abnormal repolarization. There's a depolarization theory, however, that suggests that this is because of slowing of cardiac conduction throughout the right ventricle, and particularly in the epicardium, giving a heterogeneity of depolarization, which may then give a secondary heterogeneity of repolarization, but this is the main driving mechanism for the ECG appearance and for the re-entry substrate for ventricular arrhythmias. In favor of the repolarization model is a rather complex canine wedge model that utilizes a number of pharmacological mechanisms and pacing maneuvers to try and induce a Brugada-like state. In the canine model, the ITO is very prominent anyway, and I'm not too sure that you can read the canine wedge model into human physiology, but it certainly gives a convincing model if you take its limitations at face value. The other thing in favor of it is the finding of a couple of mutations in a number of cases of transient outward current genes. The evidence, however, for conduction abnormality and depolarization, I personally feel, is more overwhelming. There are common features of conduction abnormality present in Brugada syndrome. QRS prolongation is common. Late potentials of signal average ECG investigations are common. And there have been findings from groups, including Dr. Corrado's groups, of abnormal findings at autopsy and outflow tract biopsies, suggesting the presence of both fibrosis and fat, suggesting that this may in fact be more of a myopathic picture and fit in with conduction delay in the right ventricular outflow tract. And one study on an explanted perfused heart, did indicate some evidence of slowed conduction, and in the model that they used managed to develop some raised J points on their ECG. There have been in vivo studies as well using endocardial mapping and virtual mapping, also using the ESI array. I won't go into too much detail on this, but if you look at these two pictures, the top on the left and the top on the right, well, on the left and the right, you have patients with type 1 Brugada syndrome, ECG patterns, and control patients. And essentially what is mapped over here is the activation from the apex of the right ventricle to the outflow tract of the right ventricle. And the more blue you get, the more delayed your activation is. And essentially there's a significant delay seen in conduction of electrical impulse from apex to right ventricular outflow tract, and that's been confirmed in other studies. In addition, there's been a very seminal paper recently in Circulation by Nabonnet and his group. They took around 10 or so severely affected young Thai men with Brugada syndrome having multiple ICD shocks. They undertook an epicardial study, so on the outside of the right ventricle, and established that there were these, what I've arrowed, these fractionated potentials, usually associated in the clinical EP lab with slowed conduction and abnormal conduction, and this was present and ablated on the surface of the outflow tract quite extensively. Those are those red marks over the surface. That's where we've ablated, or where he's ablated. And that actually got rid completely of the type 1 ECG pattern and removed shock frequency in all those in which it was successful. So it does potentially offer an avenue for treatment, but also adds the evidence on of the outflow tract being the responsible pathology. The original evidence for sodium channel involvement in Brugada syndrome came from a study that was related to a study of how the how mutations behaved in vitro, so in ion channel patch clamping studies. It was a temperature-dependent study. It was published in Nature. It did very well, but there was no linkage data associated with it. We didn't have a whole family of sodium channel mutation carriers in whom one could confirm the presence of Brugada syndrome. But what has become apparent if you study more and more families, and we've seen this in our experience as well, is that the more families you see, the more evidence you see of genotype-phenotype mismatch, meaning that you have carriers for Brugada syndrome in that they have an abnormal ECG, but they do not carry a family mutation for sodium channel disease in a family that already is known to have a sodium channel mutation. So even if you carry that mutation, even if you don't carry the mutation, you still carry the phenotype for the disease. So this makes us feel that the SCN5A gene itself may not actually be directly causative in many families, but may just be a modifier, and there's another substrate underlying Brugada syndrome in these families. So I think the genetics is still very unclear in Brugada syndrome. In terms of sodium channel disease, I thought I would show you some examples of the overlap syndromes present in sodium channel disease with Brugada syndrome, and these have been associated in large families with linkage studies. So you are carrying the disease if you carry the mutation. And in these cases, not only do you have failure of the inward sodium current, but you also have a late sodium current in particular that prolongs repolarization. So you may have loss of function as well as gain of function and have a long QT syndrome phenotype as well. And this is an example of one of those mutations that carries that particular mixture of phenotype. And this family, you have an individual who died suddenly, who had a sister who suffered a syncopal episode, and there are children involved as well. And those in red show abnormal ECGs, and with a plus sign are carriers for the mutation. You'll see that right on the left, number 2 sister has no sign of the disease, but is still a carrier. So in fact, you can still be a carrier for disease and have no sign just on your basic ECG. In terms of the ECG abnormalities that we can see in sodium channel disease and Brugada syndrome, this particular daughter had evidence of long QT syndrome with a peaked and late appearing T wave. She received adrenaline, and after only 2 or 3 minutes had developed this clear sign of type 1 Brugada ECG pattern. The son, that daughter's brother, had evidence for long QT syndrome and already right ventricular delay. We didn't do an adrenaline test on him. He also had those unusual T waves. He was very young. But what we did notice in him and in his sisters was that there was a degree of chronotropic incompetence in the family. Not only did you see variable T wave morphology, but you also saw relatively low heart rates for young children who should be raising their heart rates up very high generally. This is the sister who had evidence of right ventricular delay bordering on a type 1 pattern in the standard lead, a type 2 pattern here, and she was syncopal and ended up with an ICD implant. And this is the father who had evidence for PR prolongation, first degree atrioventricular block, right ventricular delay, and also sinus node disease. So there's quite a mixture of phenotypes you can find in that particular mutation, which is actually the most common mutation of a sodium channel that you're likely to see. There are around 14 families in the UK carrying that, as far as we're aware. This is another more orthodox sodium channel mutation that really is associated with conduction disease. The index case was a 42-year-old woman who had suffered from pre-syncope due to sinus node dysfunction and was found to have intermittent left bundle branch block, normal echo, family history of a premature sudden death in a distant cousin, and she had a pacemaker inserted which removed her symptoms completely. And this is her ECG demonstrating atrial pacing, but very marked conduction disease, left bundle branch block with left axis deviation. This is her brother, completely asymptomatic, and he actually presents with, and you'll see arrowed, the standard right ventricular leads, and in addition, third intercostal space ECG leads here on the right, ST elevation with a type 1 Brugada ECG pattern, and a non-specific interventricular delay. The father had a more marked conduction abnormality, and these are all carriers clearly, had partial Brugada type 1 pattern, and with ajmaline, you got quite marked and severe QRS prolongation, PR prolongation. This is common with sodium channel disease. When you give ajmaline, you make things look quite awful. You've got to be quite careful when you are doing so. And further development of those Brugada-like ECG changes, although I wouldn't say a completely classical type 1 pattern in this individual. In terms of the prognosis of Brugada syndrome, the original descriptions in the 90s suggest an extremely poor outlook. There was cardiac arrest, 20% within 1 year, 40% within 4 years would have died suddenly, and the only protection, whether you were symptomatic or asymptomatic, was to have an ICD implant, according to these survival curves from their initial description. Now, as it turns out, in fact, those who are most at risk, unsurprisingly, are those who have had a cardiac arrest already, or those who have been symptomatic, have had a blackout that may be due to an arrhythmic cause. But the asymptomatic group are in a different situation. Population studies in Japan have shown that around 1 in 1,000 individuals may be carrying a Brugada ECG pattern, but are asymptomatic and may have a very low cardiac event rate or mortality rate. These are generally middle-aged factory populations, and if you compare that to the UK general population mortality rates, that lurks around the 50s, 60s mark, so relatively similar to UK mortalities, particularly on the male side. Now, when we think of a risk for a condition that requires an ICD implant as the only recognized treatment, we think about having about a 1 in 100 risk or more to make it worthwhile per annum. Worthwhile the risk of the device, never mind considering the financial benefit, the financial considerations as well. In terms of finding those patients who may be most at risk, who are asymptomatic, primary prevention has been focusing on testing individuals with electrophysiological studies, trying to induce VT, polymorphic VT and VF in individuals who may be suspected of being at risk. The only problem is that EP studies don't appear to be a panacea or a perfect, not a panacea, a perfect predictor for future events. If you happen to be a patient in the Brugada Brothers series, you do actually have a very good positive predictive value of a positive EP study, resulting in you having ventricular fibrillation in the future. If you happen to be in a different study, however, you have a much lower positive predictive value for doing an EP study. Shockingly low, unfortunately. It can be as bad as flipping a coin. What is relatively consistent over a short follow-up is that if your EP study is negative, then you may feel a little bit more reassured, but even that may be a false reassurance given the uncertainties around this data. The biggest study to date was the finger study published in Circulation last couple of years ago, and that indicated that EP studies was useless in their hands in terms of being an independent predictor for outcome. They had around 1,000 individuals enrolled in the study, and you can see the follow-up was still only around 72 months on average in that group on this stage. But in terms of those who are least at risk, clearly the asymptomatic are 0.5% risk per annum. Those who've had blackouts higher, and those who've suffered a resuscitated sudden death, certainly higher than that. So clearly there's room for syncopal patients and cardiac arrest patients to have ICD implants, and we knew that already. What to do in the asymptomatic? If they're drug-induced or spontaneous, there seems to be a greater risk with spontaneous than drug-induced, but if you sift out the asymptomatic patients from those group, it's still low. The risk is still low, whether they're drug-induced or spontaneous. In fact, the risk with spontaneous asymptomatic is only 0.8% per annum. So we still have an issue in terms of risk stratification. What's a further fly in the ointment is a study that we undertook in our group. Dr. Raju, who's going to be speaking later, may reflect on it further. But we took around 50 unexplained sudden death victims' families and looked back in their history. And these were unexplained sudden deaths where the families had evidence for Brugada syndrome, convincing criteria for Brugada syndrome. And we looked back at their history as accurately as possible, and we could establish a history of syncope only in a minority, only around, 9 individuals there. Less than 20% of individuals had a history for syncope prior to their sudden death. And that raised the concern if syncope is your main risk stratifier for sudden death risk. And we had ante-mortem ECGs in 5 individuals, of which only 1 had evidence of a type 1 Brugada ECG pattern. So we do have some concerns about our current risk stratifiers. And when you compare that to the finger study, where we have that shorter follow-up, they had 51 arrhythmic events, so that's similar possibly to 50 sudden deaths that we were looking at, although not every ICD discharge is a sudden death. There were ICD shocks in 44 patients. Usually around half of ICD shocks may be life-saving in these sorts of studies. And there was sudden death in 7 patients. But only 10 of these events, sudden deaths and ICD shocks, occurred in the asymptomatic group. So I'm not sure that we're seeing the whole picture in the finger study either. So that there may be an element of survivor bias there. So we still have major issues with risk stratification. Cardiac arrest and syncope are high risk. Asymptomatic and normal ECG are low risk, but they are the largest group, and as you've seen, may harbor the most number of sudden deaths. Asymptomatic and a spontaneous type 1 ECG, I think their risk is still low, but not that low, and they will still be harboring risk for sudden death with a higher risk than those with a completely normal ECG. And given that the ICD is the only proven therapy, again, this emphasizes our worries about Brugada syndrome. Alternative risk stratification methods have been looked at. None have been validated across large numbers as yet, apart from being male and having a Southeast Asian background increases your risk significantly. In terms of alternative therapies, quinidine may be an option, although in the asymptomatic it's not been proven, and ablation may be an option in the highly symptomatic. The PRELUDE study I'll briefly touch on. This is the most recent investigation into the role of electrophysiological study and puts the death knell into induction of ventricular fibrillation as being a measure for risk in Brugada syndrome. All patients enrolled in the study, around 350 or so, underwent EP studies to a standard protocol. There was no difference how extreme that protocol was in terms of whether you induced VT or VF or not, and there was no difference in outcome between whether you induced VT or VF or not. There was no predictive value whatsoever. And even in the 111 or so who had their EP studies repeated, only a third had similar results from their EP studies to the first time round, so they're not even reproducible over time. There may be additional values from the EP studies over and above spontaneous type 1 and syncope. One in particular is the refractoriness of your ventricle. For those of you who aren't electrophysiologists, that's the likelihood of the ventricle being able to be stimulated after rapid pacing. So the more stimulatable your ventricle may be, the more your risk may be, and also fractionation of the QRS and the ST segment in type 1 Brugada ECG pattern may carry additional value, but this is one study, and we don't really see these ECG patterns very commonly at all, and at least I don't, thankfully. So in terms of current ICD guidelines, previous cardiac arrest is a class 1 indication for an ICD. Spontaneous ECG pattern and syncope, I would say spontaneous ECG pattern or a drug-induced pattern when you have a convincing evidence for cardiac syncope. Documented VT that does not cause cardiac arrest, I mean, I don't actually see that very commonly at all. But in terms of the use of EP studies, I'd be extremely cautious as to how you use these in terms of this positive predictive value at least. And in conclusion, you're happy to hear, increasingly important as a cause of sudden death, Brugada syndrome. Its heterogeneity in terms of genetics is high, and we really don't understand it completely as yet, including the pathophysiology. Primary prevention is the major dilemma, and the advent of new risk stratification methods would be great, and hopefully we'll be part of that sort of development in the future. And there may be a role in the future for the subcutaneous ICD, given the lower potential risks for long-term complications, or a role for quinidine in the asymptomatic that needs to be evaluated as well. So thank you for your time, and I hope I've got you in half an hour.